So, hello and welcome everyone. My name is Rohan Mishra. Today we are going to discuss the clinical series case number 2. So, we have discussed actually the two videos in this clinical series, clinical case, which is very important and which is frequently asked. I'm not saying that it is as it is asked in your exam, but it help you to understand the topic more deeper, and you will understand the thing more easily, because if you get the scenario replicating this, you can easily solve it, and you can also score good marks in your prof exam. So like without delay, we will start that the clinical case. So as you are already seeing it, before starting I will ask, I think I am audible and I am visible. I have to ask earlier as only, but let me start with the clinical case. So I have written abs paralysis or abs palsy, but actually I will start it from very basic. I will first give you the insight about the clinical case. Then I think clinical case screen is also visible. First I will read it, I will explain it, and then we will discuss that what is the most probable diagnosis and how can, as a student, when you don't know anything, you with your knowledge you can find it out. So let me start. A 32-year-old woman with gestational diabetes mellitus undergoes a difficult vaginal delivery. Okay, so you will see in later part, like in biochemistry, what I remember in biochemistry in practicals there is a GDM. Okay, gestational diabetes mellitus. So it is a condition with a pregnant woman in which there will be diabetes which got diagnosed, and you will read about various criteria, EDA criteria in biochemistry. Now I'm not going today in the deeper aspect, but you will just have to remember that in gestational diabetes mellitus the baby will be large. That is the chances of macrosomia. As a result, the delivery is difficult. That's why it is written in the first line that it has a difficult vaginal delivery. Now the fetus weighs 4.6 kg. What does it mean? That macrosomia, so the weight is more. During delivery, the anterior shoulder become impacted behind the pubic symphysis and shoulder dystocia is diagnosed. Means the shoulder is obstructed by the pubic symphysis, and this condition is known as shoulder dystocia. Now what happens is that now the obstetrician has to perform some maneuver, and this maneuver is not very important as such in the first year scenario. In this scenario, the maternal hip got hyperflexed, and as a result the obstruction will be removed from that side. But during this, there may be the chance that the angle between the shoulder and the neck will be increased. But for example, if I am not able to judge this thing, or I am not able to understand, will I still be able to diagnose it? Yes, you will be able to diagnose it, because after this you will see some features and you can easily find it out. It is a case of house paralysis. Okay, so you have to remember that during hyperflexion, during macro-Roberts maneuver, this maternal hip got hyperflexed, and as a result the angle between the neck and the shoulder will become more. As a result, there will be the injury to the upper trunk of the brachial plexus. Okay, now so after birth, the neonate is noted to have an inability to initiate the abduction of the arm at the shoulder. So after birth, the neonate is unable to initiate the abduction of the arm, and arm will hang by the side, that is adduction, medial rotation, and elbow will remain extended and forearm will remain pronated. Now this is the clinical like classical symptoms of the vata tip position. Okay, and during my time, I have used very simple technique which I want to share with you, that is APME. APME symptoms, whenever it is there, it is a vata tip, classical vata tip position. The A stand for adduction, P for pronation of the forearm, M for medial rotation or internal rotation, and E for extension of the elbow joint, elbow. So these are the classical thing of the veta tip position. We will discuss in subsequent why this position will happen, but till now you have to remember this. Okay. Now when you just got this, I will just remove all these things. So I'll you got this. Let's move to the question. Okay. So there are two things before moving to question. I will tell you there are two things which you can find it out. If you know that there is a hyperflexion and as a result, then it is very difficult for like most of the first year cannot do that. So you are like for the first year student, it is expected that with the symptoms the student can easily diagnose it as a veta tip position and it is seen in the obs paralysis. Okay, so what is the most likely diagnosis? It is the obs paralysis. Okay, very nice. Which nerves or roots are involved? Which nerve roots are involved? So it is a injury to the, it may be the injury, most likely it is will be causing the injury to the upper trunk of the brachial plexus, and the upper trunk is formed from the C5 and C6 nerve root. You already know it. So the nerve root involved are C5 and C6. Okay, it is also present in the next slide. Okay, and what are the nerves involved? So the nerves involved is MAS. I will remember it like this, that it is a mass paralysis. So mass nerve are involved: musculocutaneous, axillary and suprascapular. Okay, and if you know this thing, it is much easier to find out that why these ADI, APME symptoms are there. I can actually find it out how can this symptom will be appear. Just now I will discuss that. Okay, so just remove it and move to next slide so that we can find it out. So it is a case of obs paralysis. The keystone is the angle between neck and shoulder will become larger. As a result, it may be the injury to the upper trunk of the brachial plexus. As you already know, there is a root value C5 and C6 are involved. What are the characteristic? It is a characteristic in veta tip position, and as you already know, जैसे मैंने याद किया था, आप APME से कर सकते. The nerve involved is MAS, that is musculocutaneous, axillary and suprascapular. Very nice. But problem ये है कि हम तो जानना चाहते हैं why APME. Okay, so when there is an involvement of musculocutaneous, as you already know that the musculocutaneous nerve is the nerve which is supplying to the front of the arm. So it is a it help in, so front of the arm will be helpful in the flexion of the elbow joint. So if there is an injury to the musculocutaneous nerve, what happen is that the front of the arm muscles will be paralyzed. As a result, the flexor of the elbow joint will be paralyzed, so the elbow will be extended. I think I am clear now. As you already know that if you know it's well, if you don't, it doesn't make a difference, that it will the musculocutaneous nerve will be end as the lateral cutaneous nerve of forearm. So it is also leading to loss of cutaneous sensation of the lateral aspect of the forearm, though it is not very important, but yes. And the second thing is biceps along with flexion, it will also helpful in the supination in the semi-flexed position. So due to the paralysis of biceps brachii, as I have already told you, musculocutaneous is the nerve which is supplying to muscles, brachialis which is the major flexor, then biceps brachii, and we have coracobrachialis. So if the biceps brachii is also paralyzed due to musculocutaneous nerve injury, as a result what will happen, that there will be a loss of supination. Okay, because biceps is a supinator as well, right? In the semi-flexed or mid-flexed position, what you have to remember. And so if the supination will be lost, so P will be done, that APME. So P is, I have justified that pronation, why it happened, because supination is not there due to the paralysis of biceps. Okay, nice. And we have also we have justified that why there is an extension of the elbow due to the paralysis of the front of the arm muscle, coracobrachialis, brachialis, biceps brachii. Okay, I think it is over explained. Then we have the axillary nerve. Now axillary nerve is a very important nerve because it will be supplying to two muscles. There will be major muscle, deltoid muscle, by anterior and its division, and we have the teres minor muscle which will be supplied by axillary nerve. That's very important. Okay, as you already know that axillary nerve will be supplying to teres minor, which is a lateral rotator. It is not written, but I will help you. We have justified, so far justified this and this, sorry, this and this, it is not this. Okay, now we have to justify the adduction as well as the medial rotation. It will be justified in axillary nerve injury. The major thing is, as you already know, that axillary nerve will be supplying to deltoid, and also by the pseudoganglion it will be supplying to teres minor. Deltoid is a major abductor, so if deltoid is paralyzed, the abduction is lost, and if abduction is lost, the hand will be adducted. A is also justified due to the paralysis of deltoid, as well as we have the supraspinatus paralysis, which will be helpful in the initiation of the abduction. So that will also affect the abduction. Okay, now there is another symptom, medial rotation. Axillary nerve is also supplying by pseudoganglion teres minor, and teres minor is a lateral rotator. As a result, if there is an injury to the teres minor, we will have the justification that there will be an internal rotation or medial rotation. I hope I am clear. So now we will discuss next to the other parts. Okay, there is another nerve which will be paralyzed, MASS fifth suprascapular nerve. Actually, so what you will see, that you will feel like we have justified everything why we have extra nerve. So obviously that is also involved, and they have the same things. Okay, I will just tell you. So suprascapular nerve will be supplying to, okay, just I will move to the next slide. Suprascapular nerve will be supplying to supraspinatus and infraspinatus. You already know it. If you don't, just remember it. And if the suprascapular nerve will be supplying to supraspinatus, which is initiation of abduction. As a result, the abduction will be lost. And infraspinatus is a lateral rotator like teres minor, as I have already discussed earlier, and there is a loss of lateral rotation, so there will be medial rotation. In summary, it is also there in the picture. You can also see in the picture, it is the right hand, this of palsy. You move, okay, not it's not the end, sorry. So let me, what is the Ops point? So it is a point in the upper trunk of the brachial plexus where C5 and C6 nerve root will join to form the upper trunk, and here it is a very special point where the multiple nerves are attached. In this case, the major key point which you have to remember, I feel, which is more important, that if there is any condition when there is an angle, increased angle to the shoulder and the neck, you will see upper trunk injury, it is the os paralysis. For the first year, it is like most probably it is this. Okay, and you have to remember APME and MAS, all other things are gone. And please don't just mug up, just remember that how this approach is there. Okay, how these symptoms are there, why these symptoms are there, which nerve and which muscles are paralyzed. Okay, so that's all. Thank you for watching, and please don't forget to like, share and subscribe. Please share as much as you can with your friends who is preparing for like first of all, it is a field where you all will grow together, and you all will augment your knowledge. Okay, so together, that's more important. So please don't forget to share it, and obviously till then, keep hustling and keep working hard. Okay, thank you.